For the glitch, we will start.
Good afternoon, everyone. I, Ranjit, lecturer of JSS College of Physiotherapy, welcome you all to the 4th day of International Webinar Series, conducted to celebrate the World Physiotherapy Day. We are happy to reveal you that we had reached more than 1,000 participants worldwide, making it very interactive, informative, and a knowledge-sharing section. Today, we have with us Ms. Prity Agarwal, who has joined us from United Kingdom. Ms. Prity Agarwal is a senior physiotherapist with over 15 years of experience as physiotherapist. She has experience of working in National Health Service, UK, and in few private sectors. Prity ma'am holds a master's degree in musculoskeletal and orthopedic rehabilitation. She also has experience and interest in neurological rehabilitation. She is a qualified acupuncturist from Acupuncture Association Chartered Physiotherapist and also a qualified Pilates instructor from Australian Physiotherapy Pilates Institute. She qualified in India in year 2004 from Manipal College of Allied Health Science, Manipal, and she moved to UK in 2007 and has worked across various sectors as various roles. She has worked in condition management program organized by Department of Work and Pension and acted as a case manager for people with long-term neurological problems. She also worked in elderly care and stroke rehabilitation. She has been working in private sector since 2013. Prity ma'am has interest in research and rehabilitation and has published papers on rehabilitation. On a personal level, she is a mom to 2 young children and loves traveling, reading, and spending time with her family and children. We welcome you, ma'am, and I request you to kindly take over the session.
Thank you, Ranjit. Thank you. That was quite an introduction. And a warm welcome to all the attendees to this webinar. We are all very lucky to have this here today. Thank you to the faculty at GSS for giving me this opportunity of sharing my experience in a very concise way from last 15 years. Today, I'm going to talk about physiotherapy in community. The role of a physiotherapist in community rehabilitation is more of a practical perspective, my perspective of how I have seen it, how I do it, and how things are actually working around here. So basically, community rehabilitation is a service to help individuals reach their optimum level of independence. So once the patient gets discharged from the hospital or has, from any acute injury or has been diagnosed with any kind of limited condition, so how we integrate that person back into the community, how he gets adjusted at his home with his new condition, or how they make adjustments. So that is all about gaining their optimum level of independence, how they get about their everyday life at home as well as in the local community. I see people from, my youngest has been 4-year-old, and I've seen up to 100 years, 97, 98-year-old patients as well. I typically see them in their own homes, residential nursing homes, day centers where people go and spend some time. So if the home environment is not conducive for carrying out therapies, I also see them at day centers, and we see them in hospice where people spend the end of their lives. So the areas where we require physiotherapy expertise, it's quite a long list. We all know as physiotherapists or training physiotherapists, we all know it's a very, very long list, but it's usually reduced mobility due to recent joint replacements, could be hip, knee, any kind of acute illness or progressive condition like neurological conditions. It could be respiratory conditions, COPD, asthma, lots of other conditions. Reduced balance leading to falls. Now, reduced balance could be because of neurological conditions, could be vertigo-related loss of balance. Again, falls in elderly people, but also in younger people when they have, ankle sprains, where their joint proprioception is compromised. It could be people's decreased ability to cope with their current walking aid. So maybe they are progressing in their condition, or as they're growing older, they need new walking aid prescriptions. Any kind of musculoskeletal, orthopedic problems, neurological conditions, the list is endless. So I currently work, although I specialized in orthopedics, I see people with all range of conditions. Now, typically when I see somebody, I would do a thorough history taking, an assessment of the patient's condition, so examining him, through and through. And the main thing would be how that particular condition is impacting on that person's everyday activities within the home and in the local community, how it's affecting his integration in the local community as well. I would then set goals with the patient, or rather patient sets goals of what areas that he would like to start working with. We plan a treatment and ongoing management of the specific musculoskeletal, respiratory, and neurological conditions. I am involved in recommending or providing appropriate orthotics. It could be, people talk about any sort of like insoles, collars, braces, if they need AFOs, if they need referrals for, any custom-made orthotics, I do that. Any kind of walking aids, if they require, or if I think that would be appropriate, then I'm involved in, so as physiotherapists, we would be involved in that. Now, individualized exercise programs form a very, very important part of the therapy, because it has to be according to the patient's capacity. How much can the patient do? Can he just do his body weight exercises? Is it good enough for, for TheraBands, resisted work? Does he need endurance work? Does he need more stretching programs? Does he need balance workout? And whether he has that space at home where he can do all these exercises. Does he need to go out, access community gyms? So all of this has to be quite individualized to each patient or each person. So one size doesn't fit everyone. So it has to be very, very specific to that person, and that's what I do. Providing physiotherapy support for patients with long-term and progressive conditions is, we know, we can, from our knowledge, of seeing patients, having read about the condition, we know how things change. So some of these long-term conditions need lots of education, support. They need that empathy of, how things are changing, how we can help them with their changing environment. Referral to other agencies, if we need to involve the consultant, if the patient's doctor needs to be involved, if we need, say, a person with stroke needs to access the stroke club, orthotic department, anything. So we need to be able to refer them onto the other agencies instead of thinking we can do it all. So teamwork is very, very important. Now, I'm going to talk about Parkinson's disease today because I come across this condition or people with this condition in the community. They are not always treated for a long time in the hospital because it's a progressive condition. People usually stay at home and carry on until they have a relapse of their condition, or they need, if they have any acute illness out of the condition, that's when they are in the hospital. But most of the time they are in the community. So Parkinson's disease, just as an introduction, we all know it's a progressive neurological condition caused by lack of dopamine production in the brain. And dopamine is very, very important chemical in the brain to, for coordination of the movement, for having smooth movements through the body. And without dopamine, patients have tremors, balance problems, they have a lot of stiffness, slowing down of the movement, changes in their voice, speech, the way they write, they start writing very small and slow. They have cognitive issues where memory is affected, the thought process, dual tasking, multitasking. They struggle with those kind of things. They have urinary problems, problems with appetite, sweating, all sorts of mood changes, behavioral changes. There is a lot that goes on with a patient with Parkinson's disease. So, but nobody starts with all of them in one go. So it's a very slowly progressing, sometimes it progresses fast, but it starts with maybe like a symptom which can easily get ignored So it could just be a pendulum tremor, it could just be a little shake in the hand, it could just be a couple of falls, which we might not think much about, but eventually when patients, it takes a little while before they get diagnosed, formally with Parkinson's. So the most comprehensive care that we need to provide to the patient is obviously especially trained clinicians, which is obviously the consultant, the Parkinson's nurse. We need involvement from us as physiotherapists to maintain their muscle mass, exercising capacity, physical capacity, cardiovascular strength. We need occupational therapists input or any kind of adjustments around the house, any adaptive equipment that patient might need for their safety and everyday life. We need speech and language therapists if the patient is experiencing any kind of speech issues, swallowing problems. Nutrition forms a very important part because at some stage of the disease, when due to the side effects of the medication, people tend to eat very less, so they can lose a lot of weight. Imaging testing wise, usually they undergo CT scan or MRIs for confirming if they are having just Parkinson's disease, or if there is any kind of Parkinsonian disorder where they could have multisystem atrophy or corticobasal, degeneration. So just to make sure that they are not part of, a bigger picture, they usually have every couple of years they undergo imaging or testing. Medication is very, very important in Parkinson's disease because all the stiffness, rigidity, tremors, these are all controlled by use of medication. We have our own role to play, but we must also respect that medication. Our widely titrated medication is very, very important for these patients, that they take them on time, and it has been, fully set up for the patient and been monitored by whether the doctor or the Parkinson's nurse. And these people are reviewed in the clinics at least 6 months to a year. Every year the medication is being reviewed. Education and support forms part of the responsibility for everybody involved in this patient's care, because we all support them. It's, we educate them, we tell them what to expect and how to deal with it. Now, Hoehn and Yahr classification, basically, because the disease can be, from this time, it starts even before they're diagnosed. So it can be up to 10 to 12 years still patients can get bedridden or wheelchair bound. So it starts with unilateral involvement, progresses on to midline involvement, bilateral involvement, and then gradually the balance gets affected. And then at some point they are severely disabled, where they are still able to walk or stand, but they are limited in their everyday life. And when they progress to quite a higher stage, then they are wheelchair bound or bedridden because they are too stiff, very unsafe, because they are very, the balance is very compromised. So they are quite at risk. So that would be stage 5. Now, I've taken this just to explain our role, the role of exercise or movement-based strategies, just as we're talking about the disease stages. So the main relay is secondary prevention of stiffness, loss of muscle mass, balance, all of those things. So throughout all the first 4 stages, we are focusing on maintaining the strength, endurance, flexibility, balance, so lots of functional practice of day-to-day tasks for the patient. We also know about, we want to keep the neuronal activity going, so we are focusing on endurance, we are focusing on repetition, especially in the first stage of the disease. And we are also thinking about, this is more from physiotherapy rational point of view, where we are focusing on motor learning. So why are we doing these things? Why are we giving exercise to the patient? So because in the second and third stage, we know that repetition will keep the muscle memory, will keep the memory going on for the movement in the mind, in the brain. Feedback is very, very important, where you are giving either auditory feedback or visual feedback to the patient to improve their gait, improve their balance. We use mental imagery to help patients learn the task or keep the task going, the memory of the task going. We also make it a bit more challenging by using dual task training, where we are using cognitive as well as physical aspects. So it might be, for example, so walking and counting. So the patient is counting as part of the cognitive exercise and is walking. So getting him to do two things together, believe me, it's very, very difficult for the patient. Later on, as the disease progresses, we're providing them with lots of cues for functional tasks. So basically what we do is, you and me might get up and get a glass of water or peel potatoes or, any kind of activity around the day-to-day life. But for these patients where they have cognitive difficulties, we tend to break the task into different stages, go through them. So if I'm talking about, say, peeling of potatoes, so how you stabilize the potato, how you use the knife safely, when you stop, when do you, what do you do with it, how you chop, do you need a bigger knife, where you press. So all of this then becomes part of the training. So for you and me, it might just be peeling potatoes or chopping any vegetables, but for a patient, it is a big deal, because that's their everyday life. And as again, at some point, then we also need lots of external cues. So it could be written instructions as they are walking: do not turn here, there is a step in the front. Because of the loss of memory, they might forget that there is a step in the front of their room, they might fall. Or keeping the light on to provide them with visual cues if they wake up in the middle of the night. So we have to keep in mind a lot of these things, and this slide is mainly for your reference of why we are using exercise and movement strategies across its different stages of the disease. Because this is more of a practical perspective, I've included a few case studies of the patients that I'm seeing or I have seen with Parkinson's disease, so that would give you more of a practical ideas of how we manage patients with this diagnosis in the community. So this patient of mine, she is at the moment 49 years old, female, diagnosed with very young, about when she was 44, with Parkinson's disease. She has no history of Parkinson's disease in the family. It was, it just came on her gradually, because she initially started with pain in the neck and a lot of stiffness in the neck, and she was treated for that pain. She received injections. She was told she has got C4, C5 disc problems, which is causing a lot of pain and stiffness in the neck. But that was ongoing. It didn't solve her problem. So because she was also having falls, she was referred for neurological assessment, and that's when she was diagnosed with Parkinson's disease. At that stage, because of the falls, pain, and she was having speech issues, she had tremors. She said she was wheelchair bound at that stage, but when she received Cinemet for 6 months, it really helped her stabilize the condition. She had input from physiotherapists, occupational therapists, speech and language therapists, and from there she made a really, really good recovery, and she's now walking, doing everything that a normal person would do. But I have seen her over the last 3 years, and she had a few relapses of her condition. The pain has gotten worse. The left arm is kind of, his power is going down. She gets lots of stiffness, pain, sleep problems, urinary problems. She has balance issues. So when I assessed her, we do a thorough assessment of strength, balance, tone, tightness, everything, and then made a plan for her. So for her, the short-term goal was pain management, because she was experiencing this severe sharp pain coming down from the neck to the whole of the left arm. And she wanted to improve her left arm movement and function, because one of the things that was part of her life was cooking, and she wasn't able to do that. So that was her short-term goal. And in the long term, she wanted to, because she had stopped cooking for 6 months, she really wanted to make chapatis, chop vegetables, cook for the family. She wanted to practice outdoor mobility because she had lost confidence. So, we sat down really, and I spoke to her about the condition, what she knew about the condition, what to expect, took down all the medical history, took down what medication she's on, if she's experiencing any side effects of the medication. And then I started with, my therapy. So I use electrotherapy, acupuncture, massage for providing a pain relief, lots of stretching exercises, passive stretching, because I can stretch the neck muscles for her. She is in pain, she will not be able to do as much. So doing passive exercises, giving her, home exercise program, did lots of trunk rotation exercises, arm rotation exercises, balance exercises. And I referred her on to the occupational therapist as well, because she needed some adaptations around the house. Every time she has a relapse, I get in touch with her Parkinson's nurse. I liaise with her GP to inform them that she is experiencing some kind of new symptom, or if the pain becomes worse with our therapy input and we're not able to manage that, then we go onward for an onward referral. So my role is basically maintaining her abilities, maintaining her muscle strength, balance. I practice outdoor mobility with her, so helping her manage her everyday life, even though knowing this disease is going to progress. But the important thing is she's able to live her life with the condition. The condition does not dictate what life she lives, basically. And some of the other problems that she experiences currently is reading, concentration-wise, memory. She has lots of behavioral issues as well, but yes, she is under a counselor for dealing with her anxiety. So that's the first patient. I also saw a 70-year-old male with diagnosis of Parkinson's disease, and his main issues were stiffness in the back and legs. He had shuffling gait, a very typical shuffling gait, which led to his diagnosis by the consultant, basically. So, and then gradually, as he progressed on with the condition, he had balance problems, mobility difficulties. And with him, my main area of work was stretching and strengthening exercises. I used to see him every couple of weeks. So, mobility practice with a walking aid. I issued him with one of the laser cane sticks, which you might have heard of, because he was freezing a lot. And he found it very, very useful because, when with a laser cane stick, it has a sensor. So if the person stops or freezes while walking, you can press it and that gives a laser light, and then the person starts stepping again. So, but if you don't have a laser cane, even otherwise, there are lots of strategies that we could use. People start counting, or they tell themselves move. So you teach them to use a verbal cue if verbal cues work for them. If verbal cues don't work, then we use the visual cues. So I've not seen him in the last few years because he has ongoing limitation with mobility, and currently he's considering moving into a care home because of his increased care needs. But yes, I saw him for like good 4 years as well. There was another patient I saw for a brief period of time. He was a 65-year-old male diagnosed with Parkinson's for like about 30 years. So, and he looked amazing. He didn't look like a Parkinson's patient at all. When I first met him, he had very minimal deficits, and all he wanted to do was work on his, general strength and balance. But then, 2 months later, he had a relapse, and he was very unsteady, stiff, and housebound. He was not the same person. So there was a very different approach to, all the three patients, or even in his case, where we would use different techniques, we would use different exercises, or different management strategies that we would use with these patients, depending on which stage of the disease they are or what their current problems are. So that's kind of summarizing. It was very hard to summarize, but yes, that's kind of summarizing my experience with some of these patients. I included a recent research because there is a lot of research where they have what they have done with Parkinson's, the role of physiotherapy in Parkinson's disease. And this was a very recent one published in October 2019 in Movement Disorders Journal. And they critically appraised and conducted a systematic review for 83 clinical trials, which had, exercise interventions in Parkinson's disease. So they had multimodal exercises for 60 minutes, twice a week for at least 12 weeks, when they were included in the study. And they really recommended that increasing physical activity levels in Parkinson's disease with exercise and physiotherapy programs is the best thing. So now, I would suggest from my experience as a physiotherapist is we are therapists, so we need physical rehabilitation as well as emotional healing for the patients, because some of these patients, or most of us, when they have physical issues, it never comes alone. Whenever we have a physical limitation, we're always worried. We are worried about how we are going to cope with the rest of our lives, how we're going to cope with our children, family, work, So we have to listen to the patient. When we listen to the patient, we find out the areas of their difficulties, and that really, really helps on how we are going to tailor our program, our therapy towards making their life easier. So we need to empathize with our patients, so we can look at, we don't need to sympathize. Nobody needs sympathy. Everybody, needs to be empowered about how they face these challenges, how they're going to practically manage even with some of the deficits. So we have to, as I said, thinking outside the box and thinking about day-to-day activities, whether we need equipment or just some practical solutions, to make sure our patients are safe and they're able to do their day-to-day tasks. I've just put an example of, if they are struggling, say somebody is struggling with getting in the car, then we can look at, so is it because the car is too high, we provide a footstool, or right, they have difficulty turning inside the car, then we can use a disc or something slippery. So once they are in the car seat, they can easily turn in. And the same thing when they are coming out. And we can, over here in the UK, we use lots of equipment, if it's available. If not, then we make sure the patient is as safe as possible. So get creative with tools in your box. So hands-on approach really, really helps. Exercise therapy, even when I prescribe exercises, I always do them with my patients. So I never show them any stretching exercises. I stretch them. So they know the feeling. They know when it hurts, when it's good hurt, when it actually is effective stretch. And then I let them do for themselves. So when it's exercise, we do lots of repetitions of exercise so the client can actually feel the muscle working. So if I need to massage, I will massage my clients. I will use manual therapy. I would use electrotherapy. If my client is suffering with pain, I will go over and beyond with whatever is in my toolbox to make sure I have done my best. And if I've done my best, and if the patient needs medication, I will always refer him on to the general practitioner for any pain medication that might help. I would use, I would always assess my clients for the best kind of exercises, whether it's free weights, TheraBands, dancing. If people are struggling with coordination, sometimes dancing to music really works because it's like enjoyment for both of you. But yes, people like, so if people, if patients like music, then dance is a good form of exercise as well. And I believe patients are the best teachers because patients are the experts of their condition. So if we listen to them, we learn a lot from them. I remember a lot of my conditions because I've seen those patients. So I relate to, so it helps me in my learning. I always write down if I learn anything, I always write it down. So always write your reflections following any learning event. So that's the most important thing that I would like to share. Right. Any questions? That was a lot of talking.
Thank you, ma'am, for the brainstorming section. We have few questions, ma'am, from the student side. Okay, can I ask you, ma'am?
Yes, please.
Yeah.
I will
Okay.
try my best.
Okay, one of the question is, does exercise replace Parkinson's medication?
No, it doesn't. As I said during the presentation as well, some of the symptoms, mainly rigidity, stiffness, tremors, we can't replace them. They have to be managed with dopaminergic medication, and that is the way to do it. What we can do is secondary prevention. So, say if they are on medication, so because of the tremors, because of stiffness, if there is reduced use of any part of the body or any of the muscle, then we can train them. But it has to be, with the effect of the medication.
Thank you, ma'am. And the next question is, how is acupuncture beneficial in treatment of Parkinson's?
Acupuncture is a different science. When I learned it, it was just amazing. So acupuncture helps because it has a lot of science. In China, they have done thousands of years of research on this, and it stimulates. So when we needles in specific areas of our body, so it stimulates the part of the brain, and they have seen this in brain mapping. So they have put needles in the body, they have done brain mapping, and they have seen the changes in circulation, and they have seen it affects locally as well as centrally. So when I use acupuncture for my Parkinson's patient, it is mainly for pain management, because it helps with flow of energy. So if there's any stagnant energy staying in the body because of the stiffness, it helps with that. It helps with increasing the blood flow in the area, because you are kind of doing micro trauma to the tissue when you insert the needle, and you facilitate the flow of blood. Thinking about it in an orthopedic way, you are kind of treating a trigger point. So, if there is a trigger point in the upper trapezius muscle, which is very common with stiff neck and, with neck pain, so you are actually treating that as well. So that's how I feel acupuncture really, really helps in Parkinson's patients.
Thank you, ma'am. I have one more question, that is, will you prefer an active or passive type of exercises more?
I would always, so it depends on the client. So if my patient can do active exercises, they are the best form of exercises where they stretching will cause more motor programs in the neurons. They will have the repetition will really, really help with remembering the movements. It is their muscles. They need repetition. They need the resistance. They need the work for their muscle memory and muscle building. So passive exercises are only helpful if patients can't do them. So if they have maybe too much of stiffness, they are very, very weak, I would do the stretching. I would do the work for them. I would assist them in doing it, only to maintain the range in the joint, or even to maintain the range in the muscle legs, basically, or to keep the circulation in health of the tissue really.
Okay. And one more question, ma'am. What challenges do you face in exercise prescription, follow-up, and family support in Parkinson's patient?
Yes, that's a very important question. Because I think the exercise compliance is a very big thing. But when patient, so it all depends on the motivation of the patient. So if the exercises, this is why it is very important that we assess the home environment for the patient. So is the patient able to do exercises at home? Do they understand the benefits of those exercises? Why are they doing them? So this is where the education really, really helps. So if I'm able to express this to my patient, make it clear that only if you do these exercises can you can expect to improve your balance. So doing this with me once a week is no good. So I'm always upfront with them. I always tell them, so you have to do this when I'm not here. I would always ask the family members to, you know, to provide them, with motivation and support to do these exercises. What also helps is sometimes the patient, if they might, so it's not like pestering for exercises. Mom, you need to do these exercises. It's about them being involved. Sometimes, family gets involved. They do exercises. Children do exercises with their parents, and that's that motivates them. Or going out as a family. So that's like instead of my patient going alone outside for a walk, the family member might like to accompany them, or going to the shops. So that means we set functional tasks for them. So I would ask my clients, so maybe next week, if you can go out to the shops and buy something for yourself, that would be like a goal achieved. So they might go out. So that's like outdoor walking. They go shop. They're standing on their feet, pick up objects. They pay the shopkeeper. So they're using their cognitive skills. They're walking back. So it works in a lot of ways. So yes, involvement from everybody is very, very important. I can't hear you, Andrew.
Okay, sorry. Thank you. The one more question is, what areas in motor learning is to be tackled in Parkinson's patient?
All areas of motor learning really, motor learning is more of, you could be using more of, I would say, repetition, dual task training, those kind of things, because it's the repetition, because memory is one thing that gets affected in Parkinson's along with, other physical factors. So you want to repeat the movement as much as possible. And, cues, visual cues, so cueing, repetition, walking, reflex, so, gait training. So all of this, I think it's an integration. It's how we perceive motor learning to be, but, it's not one concept, but it's a combination of everything, of all the principles of motor learning.
Prity, there's a question that Ranjit missed. It says, what's your opinion on virtual reality in management of PD?
Yes, virtual reality is very good. It's a very upcoming area. Lots of therapy centers are using it. And it is mainly for gait, balance, those kind of things. It is useful, but it is about how much of it is practical for the patient in everyday life. So just doing it for a period of time, because these are quite expensive equipment. One of this, I think, is virtual reality is, yes, it is an expensive piece of equipment, and for them to be able to use it safely is not a question. So they have to be, using it under supervision of a trained person for working on their gait, balance, on those aspects. But yes, the effects of learning from there would be, if they can, take it into their everyday life, that would be really, really good. So this is like more upcoming thing. When you spoke about virtual reality, ma'am, one other thing, Nintendo Wii was also being used quite a lot for training balance in these people, and dual training, where they're playing games. So they were moving around and moving their arms as well. So that is also quite successful, but it all depends on what stage of the disease of Parkinson's they are really. So, if they are in the first two stages, I would think that would really be beneficial.
Ranjit, you're not audible.
Sorry. Ma'am, your suggestions on fall prevention exercises in patient with Parkinson's disease, ma'am?
I use very basic, the same old school concept. So I would use walking forward, knee marching, sideways walking, backwards walking, tandem walking, single leg stand, squatting, sit to stand exercises. I'm always with my basic exercises, and they always were. Whereas if you, I mean, I also do lots of coordination work with the patient, so arm swings or while they're marching, um, again closing their eyes to take away the vision support, and so that they're relying on their joints and their limbs for balance. Sometimes you could use a little bit of a nudge and those kind of things, but yes, I'm always with my basic exercises, and I think they work.
There is a question, interesting question. Passive exercise, don't passive exercises make the patient more dependent?
Yes, passive exercises, but it depends on at what stage of the disease, as I said earlier. So if they are in stage 5, they would need passive exercises to maintain joint mobility, for maintaining the muscle length, circulation. In the first 3 stages of the disease, definitely active exercises work more. When I said I would always do passive stretches for them, it's for them to feel the stretch, for them to feel the movement when I finish with, during the therapy session, it's what I would do for them. But yes, active exercises are always.
There's another very interesting question. Ma'am, what quality would you feel is required for a therapist while treating their patient? That's like a Viva question.
I would say a very open mind. So, very open mind, good ears to listen, not to hear, but to listen to your patients. Keep your eyes open, see your patients as a whole, see how they're moving, see how they're sitting, listen to them. Because I find, when I see my patients, I find nobody has listened to them enough. They go and see their doctors, they're out in 20 minutes. Nobody has listened to them enough. Their everyday difficulties. So it might be getting out of bed. A consultant is not worried about if the patient can't get out of bed. He has prescribed his medication, he's done the job, he's done the investigation. But yes, I, as a therapist, I am worried if my patient can't get out of bed. If he's laying there waiting for his carers or family, how can I make him independent? That's where my brainstorming would start. So as a therapist, I think having lots of patients, don't mind using my hands in supporting my patients. My brain is always open, my eyes are open, my ears are open. So keep your senses open, I would say. Did I answer?
Okay, Ranjit has got some challenge with his microphone, I think. So which exercises will you precisely focus more in PD?
In PD, aerobic exercises have been shown to, to be very effective. So increasing their physical capacity. So if patients are able to walk, so can they walk faster to increase their, endurance and exercise capacity? If they can do biking, if they can do swimming, in any form of exercise, if they're playing any sport, if they need, if they can go back to it with medication, with your support, with with exercise, whatever they need. So whatever activity of choice, I would really focus on that, along with, if they have specific areas of weakness or inadequacies, then we would work on that separately. But resistance exercises, if they like going to the gym, all of these is very, very good.
Another question is physiotherapy required only for secondary prevention and management, or can there be a slight reversal of conditions seen? I don't know what that question means. Maybe you do.
They mean to say, I think what's being asked is, can we actually halt or, reverse the progression of the disease? I don't think it would be, I think I'll be overestimating myself if I said I can reverse somebody's Parkinson's disease. Yes, people do get better. So say when I was seeing my first client, she was already on her medication. she was at optimum level of medication, and she still had, the arms, the tightness, the swelling, the pain. And with physiotherapy, I was able to improve that, but I can't say I stopped the progression of her disease. If it was that, 6 months later, she would not have another relapse because I'm still involved with her. And we are still doing what we are doing. So it's the natural progression of the disease, and I don't think we can reverse it.
Thank you, ma'am. Ma'am, is there any difference in approach to treatment of patient with Parkinson's after relapse? I think relapse they might have been on and off phase.
Yes, on and off.
Any difference?
The on and off phase of the medication, or whether it's a relapse. So if it's a relapse, yes, I have a more gentler approach, because a relapse really shakes the patients because they are confused at that stage. There is more pain, more stiffness. They suddenly get really limited in their abilities. So whatever they could do last week, they can't do anymore because they have been, there is a change in the condition. It's usually they are struggling with their sleep, whatever were their symptoms, they just get worse. So I have a more gentle approach, and I take it day by day according to the patient. And I tell the patient the same thing: if you can't do certain things, just wait. When this medication, works optimally again, we will get there. And it's a time and patience thing. They have to, we have to be more patient when they have relapse. So I continue to focus on the symptoms management at that stage when they have a relapse. And once they have stabilized is when I go back and start working on the same conditioning, strengthening, and other things.
Thank you. Okay. When would you tell the truth regarding the progress of PD to the family and patient?
That is not really my role, because every Parkinson's patient is very different. Not everybody progresses at the same speed. And I would just give an example of one of my patients who was told by his consultant in a very rude way, I would say, his first appointment, that you would be wheelchair bound in 10 years. And that was like a challenge to the patient. So, when I met him, he said, 6 years, I'm doing really well. 8 years, I'm doing really well. I'm still not in the wheelchair. So they are fighting, and he's not in the wheelchair. He's still not in the wheelchair 10 years later with this diagnosis. So who can say how this is going to progress? All I tell my patients is to be patient with this disease. Yes, it is progressive, and I am never lying to them about it. And it is very important that the family knows about it as well. And it is a truth that it is a progressive condition. Every relapse leaves your client with a little bit more deficit than they had before. And it is very obvious to the patient, they can feel it as well. So it's a truth of life, really. And I'm not going to tell them you're going to live for 8 years. I'm not God. I don't define birth and death. So, I would only tell them that this is progressive, but we can make it better. Let Parkinson's not define you. You define your disease to the best you can.
Yeah, ma'am. One last question. The telehealth has become the new normal. So how would we treat a patient with Parkinson's disease virtually?
Yes, that's quite challenging, because I find my hands are quite limited when I do virtual consultation. But I have done virtual consultations in COVID, because obviously my patients were shielding, and so I didn't see them. But it was more, so virtually you can assess the movements, you can also listen to your patients, the concerns. If you think they need to talk to their doctors, or if there's anything to do with the medication, you can always advise them. Apart from that, pain management wise, I advise them with a heat and cold therapy. You can show them exercises virtually, and also observe them doing it. So that's how you would monitor. You can set them exercise prescription about repetitions. You can print out the exercises, send them by email, or post it to them, and talk to them, follow them up, whether video calls or telephone calls, how best you can.
Can you take one more last question, ma'am?
Yes.
Yeah. Right. So strategies for trauma control, ma'am.
Strategies for trauma control. Yes. I mean, it's very unfortunate, isn't it, with the condition, because they can fall. They can fall at any time. They can, turning around. So they have to. So you can use visual cues. You can use lots of dual task training with your patients. So you train them. So when they're turning, they have to turn slowly. So you train them for that. And always kind of I try and fight this shuffling gait with my patients. I always tell them knee high marching, knee high. I shouldn't be able to hear the slippers noise, on the floor. So I always tell them lift, so I'm not able to hear. So they know that they are not going to trip to fall. They and obviously that they should have lights on at night when they are, because when you're half asleep, you're not very aware of the environment at night. So in the night lamps on, not having any drugs to around your immediate environment to prevent any tripping hazard. Having everything. So taking your medication on time, that's the most important advice I would give them. They are in control of their condition. Apart from that, hip fractures are quite common with, because they have limited mobility, osteoporosis. As the disease progresses, there is less weight bearing. And something that I used in one of the care homes was a hip protector. So the research on it is not very, what do you call it, not complete yet, but you get hip protectors that patients can wear like their underwears. And if they fall, that protects their hip bones because that takes the impact. So that's something, if a patient is osteoporotic and is at very, very high risk of fall, that's something to consider as well.
Thank you, ma'am. And sorry to interrupt you. One more question. What is your opinion on deep brain stimulation, ma'am?
Deep brain stimulation, it is basically a form of treatment for patients with Parkinson's. Not everybody qualifies for that treatment because there are certain criteria for it, that if you have responded well to dopamine agonists, but you have come up to a dose, a really, really high dose where you can't do it anymore, that's when they give you deep brain stimulation. But there's a lot of things to think about, is because there will be an implanted device and you'll be getting stimulation to your brain. And this is when it's done, if it's effective, it's really effective. It improves the quality of life of the patient, but not everybody qualifies. So that once there is something invasive in your body, it is, it has got its own dangers, or that you have to make decisions about, because it can cause infections. It can, long-term effects of deep brain stimulation can be damaging as well. But yes, fact-wise, what I've heard from patients is really good. Like if it works for them.
Thank you, ma'am. Thank you for answering all our questions. I'm happy, and we are overwhelmed for your brainstorming section. Thank you.
Thank you so much for listening today. Thank you for the opportunity.
Thank you, Prity.
Thank you.
Bye. Thanks.
Bye. Thank you.